It's really a pleasure to be with you all this Saturday. It's great to see so many familiar faces, and just again a shout out and thanks to the MDA and also to the industry sponsors for this event as well. Just another word about the MDA care centers which were identified. There's also a very excellent clinic in the Kaiser system as well that's very well connected with the MDA and with clinical trials, and provide great care for patients in the Kaiser system. This morning I'm going to focus on an overview of the clinical trials and therapeutic approaches in Duchenne muscular dystrophy, and I think some of this is really going to be new for many of you, because there's really so much happening in the Duchenne space right now. Just as a matter of disclosure, I do consulting work on Duchenne muscular dystrophy clinical trials for a number of industry sponsors who are conducting research in the Duchenne space. Just to start with, let's focus on the consequences of absent dystrophin levels. And what happens when you have reduced levels as in Becker dystrophy or absent levels as in Duchenne dystrophy is here's a muscle fiber, and essentially you've got this weakened muscle membrane here, which is prone to focal tears or injuries in that muscle membrane during just normal everyday muscle activity and contraction. And that actually causes a massive influx of calcium into the fiber, an activation of destructive enzymes or proteolytic enzymes. The calcium that actually leaks into the muscle fiber can actually be directly toxic to mitochondria. Mitochondria are really the energy factories which really help with the day-to-day activities of the muscle fiber and are critical for muscle regeneration. So as I'll get into later, there's an increasing emphasis on trying to improve mitochondrial function and improve the bioenergetics of the fiber. But there's also a real need to also deal with this activation of these destructive enzymes and the inflammation that occurs within a muscle fiber. And oftentimes when fibers are injured, they undergo what's called segmental necrosis. So it's not the entire fiber which is damaged. It may just be a portion of the fiber, but that really impacts the overall function of that muscle fiber. So if you think about Duchenne pathomechanics, there's a structural defect in the dystrophin protein. The muscle membrane is unstable. The muscle fiber undergoes degradation or necrosis. There's inflammation in the muscle fiber. And then eventually the muscle fiber can be replaced by scar tissue and fatty tissue. So you can see here's a normal muscle biopsy specimen. Here's a muscle biopsy specimen in a patient with Duchenne. You can see all the fatty infiltration into this specimen. There's a lot of scar tissue. There's inflammation and so forth. Eventually the muscle fiber undergoes fiber death, or irreversible death. But this is not just a one-way process. There's actually a lot of back and forth degeneration and regeneration which can occur in the muscle fiber. So looking at it a different way, you've got a primary gene abnormality that causes an absence of the dystrophin protein. The muscle membrane is then susceptible to injury events. There's then this cascade of events leading to muscle fiber injury and destruction, degradation of the muscle fiber. And so the muscle fiber itself undergoes cycles of degeneration, regeneration, degeneration, regeneration. And you actually have to have what are called satellite cells involved in that regenerative process, which we'll speak about here momentarily. And then eventually, unfortunately, the fiber will undergo irreversible cell death, and that fiber then is replaced by fat tissue and connective tissue. So the goals of all these therapies are really to enhance regeneration, reduce inflammation, and really try to prevent this irreversible muscle fiber death from occurring. So that's really the goal. So with satellite cells in muscle, here's a muscle fiber. You've got this sort of isolated area of destruction, there's these satellite cells that actually lie on the outside of the muscle cell. And those satellite cells can actually undergo differentiation to really precursor muscle fiber tissues, myoblasts, and then what are called myotubes. Those myotubes can actually cause bridges or repair through that destructive segment. So essentially these satellite cells can differentiate into these multipotential or essentially stem cells. They can differentiate into fibroblasts, which may just cause scar tissue, or they can go down a pathway of promoting regeneration of the muscle fibers. So again, back to the satellite cell issue here. So you basically have a muscle fiber, you get trauma or destruction to that muscle fiber. It's really kind of a focal injury. It's not the entire fiber isn't damaged. These satellite cells, which are sort of the important precursors to muscle cell regeneration, they get activated. There's actually growth of these satellite cells, or they proliferate, and then eventually they lead to regeneration of new fibers. So there's these cycles of destruction and regeneration. Here's a different picture of it. You see there's injury here. The satellite cells will then proliferate. They will migrate and eventually form these myotubes, which cause essentially fusion and repair of the muscle fiber. And then you get essentially a regenerated muscle fiber, which is functional again. So a lot of the therapeutic approaches are really to try to enhance this process, decrease the inflammation, improve the energy available for the regenerative process to take place. There's one other factor I should mention, and that's this pathway called NF-kappa B, which is chronically activated when you have inflammation in a Duchenne dystrophy patient. And the NF-kappa B is actually the target for steroids, and all these new designer steroids actually target this NF-kappa B pathway. So many patients are on steroids, also called glucocorticoids. Interestingly, when there's this inflammation, there's actually these microRNAs also inside the muscle fiber, which have an impact on the actual expression of the dystrophin protein. So the microRNAs are actually elevated when you have inflammation. They actually will increase with disease severity. The inflammatory cytokines, or these inflammatory molecules, will actually create more microRNAs. But the anti-inflammatory medications like the steroids actually block the expression of the inflammatory cytokines and also reduce the amount of microRNAs that you have circulating around. So this actually causes a potential sort of synergistic impact of steroids for some of these new dystrophin production or dystrophin restoration strategies. So if you treat a patient both with, say, exon skipping or gene therapy, and you can also target with steroids or some other type of medication this inflammatory pathway, you actually might knock down these microRNAs and actually make the gene therapy or the exon skipping work even better by producing even more dystrophin. So that sort of gives us this concept of the importance of some of these combination therapies. We should note that in terms of standard of care, there's really critical management that goes on in our clinics on an everyday basis. Patients treated with steroids. They're approved here in the U.S. with Emflaza, with deflazacort. Many patients are on prednisone as well. Management of spine deformities. Steroids actually will help prevent scoliosis and spine deformities, but timely surgery, respiratory management with airway clearance strategies or mechanical cough assistance devices, non-invasive ventilation, cardiac management, which you'll hear about again later today from Dr. Dion, afterload reduction and recognition and management of heart failure. And then what we'll focus on this morning is these novel disease-modifying therapies, which are really very exciting. Just a word here about standard of care. If you actually look at the survival data on Duchenne patients from the 1960s, when we really had no treatment, to successive decades, the survival has actually gotten better and better. And if you just look at the use of nighttime nocturnal ventilation plus the application of spine surgery, just with those two interventions, survival has gotten quite a bit better, and many more patients are living into their 30s. Here's data actually showing that Duchenne survival is impacted primarily by ventilation. This is two separate studies which actually show the median survival in patients who were not on BiPAP or bilevel ventilation, nocturnal ventilation at nighttime, survival into the teenage years, and they survived almost 10 years longer if they just did the simple intervention of nocturnal ventilation. Steroids itself, this is the survival with steroid treatment. This is the survival curve without steroid treatment. And even something as simple as afterload reduction with some of the heart medications that many patients are on, such as ACE inhibitors, has actually had a dramatic effect on improval of survival in patients with Duchenne dystrophy. This is actually demonstrating the stages of Duchenne dystrophy. You have this early stage of delayed or impaired acquisition of gross motor milestones and motor skills, an early ambulatory stage where there's just a modest functional decline, a late ambulatory stage where there's a more rapid functional decline, early non-ambulatory stages where patients will have impairment of overhead reach and hand-to-mouth function, and eventually a late non-ambulatory stage where patients are requiring non-invasive ventilation and daytime ventilation in addition to just previously just requiring nighttime ventilation. And then also loss of distal hand function, which occurs in that late ambulatory stage. The clinical trials will all use different endpoints depending on what stage these patients, the patients with Duchenne are in the disease progression. And again, a lot of these clinical trials will actually be targeting particular stages, not because these therapeutics only work at a given stage, but it's really has to do with the ability to actually demonstrate a benefit in a short period of time, say a 1 year or an 18-month clinical trial. So just to start with, the impaired ability to hop, run, jump, rise from the floor, this period of delayed and impaired acquisition of milestones, this is actually the group that are being targeted now with some of these new designer steroid treatments, which have better side effect profiles. Now, if these trials actually show a success and better effectiveness or better safety in these with these designer-like steroids, those steroids could then be applied to other stages of the disease. But this is the stage of the disease where those trials are targeting. Similarly, with the initial gene therapy trials, it's largely this 4 to 7-year-old population that's showing delayed or impaired acquisition of the gross motor milestones that are being targeted initially with the gene therapy trials. Here's just an example of a child actually treated with steroids who actually is able to hop with steroid treatment.
Okay,
now, most Duchenne patients actually never develop the ability to really hop consistently, but with steroids, this child can actually hop, and here he's actually seen on the right, able to jump, again, with the steroid treatment. Similarly, we oftentimes will time the rise from floor in a Duchenne patient. Here's a very young patient.
You want it?
Here you can see his sister is sort of encouraging him to get from the floor, rises with a push off the knee, so-called Gower sign. That's actually timed in some of our clinical trials, and then the ability to actually run with both feet off the ground in a young patient with Duchenne. These are some of the functions that are looked at in these clinical trials. And here's an example again of a patient who's 9 years of age. You can see getting off the floor with the classic Gower's maneuver, pushing off the knees, and then unable to sit from a standing position without the assistance of the arms. Here he is trying to jump, trying to hop on one leg here, trying to jump previously. Here he's performing the 6-minute walk test. You can see a very characteristic gait pattern. Difficulty just taking a step off the bench. So these are the maneuvers in the so-called North Star ambulatory assessment, which is increasingly being used as a clinical endpoint for some of these ambulatory clinical trials. So as I mentioned, we have these, most of the trials to date have oftentimes focused on these patients in an early ambulatory stage or the late ambulatory stage. But I think what's exciting is we're actually seeing trials that are extending now into the non-ambulant population and to younger patients as well. So we're seeing trials now extend beyond this ambulatory phase. This was some data we published in the Lancet last year showing the advantage of steroid treatment. The red data points are those who are treated with steroids, and it shows the proportion of patients that are still able to walk or ambulate. And the blue is the patients not treated with steroids. And steroids, actually, the median age at loss of walking ability was about 13.4 years in those treated with steroids, about 10 years of age in those not treated with steroids. So steroids actually prolong the ability to walk or ambulate by about 3.5 years. But now we're actually increasingly focusing on upper limb function. We have some really exciting new assessments that allow us to objectively assess upper limb function. So we have patients that we want to try to preserve their overhead reach, their ability to feed themselves and get their hand to the mouth, and distal hand function as well. If you just look at the steroid data, what's really quite striking is the age at loss of full overhead reach. So even the non-ambulatory patients that were treated with steroids, they actually lose overhead reach about 3 years later, and they lose their ability to get the hand up to the mouth independently by almost 5 years prolonged or later with steroid treatment as opposed to without steroid treatment. And what was really quite striking in this article we published in the Lancet, if you look at the age at which patients lose distal hand function with steroid treatment, about 31 years of age on average, and without steroid treatment, they lose distal hand function. Patients lose it at about 23 years of age. So about an 8-year prolongation of distal hand function with steroid treatment. It's an exciting time. In the year 2000, there were fewer than 10 clinical trials in Duchenne muscular dystrophy. By 2014, there were 121 Duchenne studies of either diagnostic tests or treatment strategies, treatment trials at various ages. And it's even exploded since 2014 to present. There are a number of organizations in addition to MDA which are involved in Duchenne research. This just shows a partial list of the number of organizations. It's really just exploding. The number of pharmaceutical companies, advocacy groups, academic centers such as UC Davis, UCLA. You'll hear from Stan Nelson later today. And a lot of work going on developing these therapeutic mechanisms and drugs for Duchenne. Now, for Duchenne dystrophy, there are classic approaches that are in development. Dystrophin restoration is obviously probably the most important, but there's also focuses on inflammation, blood flow, mitochondrial health, mitochondrial activity, muscle growth, muscle protection, and then focuses on calcium regulation as well. If you look at, again, just steroid treatment, in and of itself, the reduction in risk of death just with steroid treatment is about 50% risk reduction in terms of reduced death risk just with steroid treatment. So there are really 6 main categories of therapeutic targets for Duchenne. We mentioned replacement of dystrophin, decreasing inflammation and fibrosis, increasing muscle mass and regeneration, correcting blood flow, correcting abnormalities in calcium handling, and then increasingly a focus on mitochondrial dysfunction or bioenergetics. So I think what eventually we're going to see is that patients with Duchenne are going to be on multiple therapeutic agents. It's going to be a cocktail of therapeutic agents to try to improve function and slow down the disease and actually stabilize the disease, much in the same way as treating a cancer patient with perhaps 3 or 4 different chemotherapeutic drugs. So just to start with, in terms of this focus on inflammation and muscle fibrosis, as we mentioned, NF-kappa B is chronically activated in Duchenne. Prednisone targets this. Deflazacort from PTC Therapeutics is FDA approved in the United States, the only steroid that's FDA approved. And there are current ongoing trials looking at designer steroids with better side effect profiles, one being vamorolone from Reveragen is a so-called dissociative steroid. We think it may have decreased side effects. There's another medication, a small molecule called etosolonexant from Catabasis, which actually has a linked aspirin-like molecule, salicylic acid, and docosahexaenoic acid, or essentially a fish oil compound, both of which actually decrease inflammation. These molecules then get cleaved once they get absorbed intracellularly, both these molecules will inhibit NF-kappa B. Givinostat, we're doing a Givinostat trial at UC Davis. It's an HDAC inhibitor, which decreases inflammation, improves muscle strength, and seems to enhance regeneration. Fibrogen, which is a company out of San Francisco, has pamrevlumab, I should say, fully human monoclonal antibody that inhibits the activity of connective tissue growth factor. So it targets CTGF. So this Fibrogen compound actually hopefully will enhance both inflammation and also fibrosis, or the scar tissue. CAP-1002 is a stem cell treatment that we have recently shown has some benefit in patients who are non-ambulatory, and this seems to decrease inflammation, fibrosis, and enhance mitochondrial function as well. A word about the myostatin inhibitors. These two from Pfizer and Roche were investigational. Just this last week, just a couple days ago, we heard that the Roche trial, in addition to the Pfizer trial, both these trials now have failed. Both these trials have been discontinued in Duchenne. Part of the issue with myostatin is already downregulated to a large extent in Duchenne patients. So the degree to which you can further decrease myostatin in a meaningful way probably is not going to pan out to have a therapeutic effect in Duchenne. So these trials have largely been discontinued in Duchenne dystrophy, really all the myostatin inhibition approaches. That doesn't mean it might not work for other muscle diseases or muscular dystrophies, but it just doesn't seem to be working in Duchenne. Now, there are really exciting approaches targeting dystrophin restoration. Stop codon read-through, Ataluren from PTC Therapeutics. There's a US trial ongoing. This drug is actually approved in Europe for patients with, who have stop codon mutations. Antisense oligonucleotides, Wave has a stereopure antisense targeting exon 51 that has been moving into clinical trials in humans. The so-called PMO form of exon skipping drug, Sarepta, targets exons 45, 51, 53. NS Pharma has a drug which is targeting exon 53 with this. There's another form of a PPMO where you actually attach a small charged particle or peptide onto the PMO and actually drive more of the PMO into the cell. Sarepta has a PPMO, which is under study. And then we'll talk about AAV microdystrophin gene therapy as well. I mentioned that there is this really exciting focus now on the bioenergetics, or really targeting this mitochondrial dysfunction that occurs in Duchenne muscular dystrophy patients. And there's actually one trial that's ongoing right now, Idebenone from Santhera Pharmaceuticals, had really very promising data in non-ambulant Duchenne patients with regard to preservation of pulmonary function. They're doing another large trial in steroid-treated patients. This is a CoQ10 analog, which is actually more potent than CoQ10, that actually targets mitochondria, and that looks very promising. Astellas has a medication class that's referred to as a PPAR delta agonist, which also is targeting mitochondria. And then we conducted two studies here at UC Davis on Becker muscular dystrophy and then Duchenne plus epicatechin. And this is moving forward now with significant investment from venture capital to develop plus epicatechin. This is a drug which actually induces mitochondrial production or biogenesis in Duchenne patients, and there's a significant investment in bringing this drug to clinical trials in both Becker and Duchenne muscular dystrophy. PTC Therapeutics just acquired this company, which has this compound, EPI-743, which is a parabenzoquinone, which targets really oxidative stress. This is promising in animal models. CAP-1002, which is the stem cell approach, actually is probably we'll see further trials of this in Duchenne patients, probably, again, non-ambulant Duchenne patients. Now, there are a number of mutation-specific interventions in clinical trials right now. Sarepta has a number that they've conducted clinical trials in. PTC Therapeutics targets this stop codon mutation. NS Pharma actually has an exon 53 drug. They also have an exon 44 drug in the pipeline. There is another company that has an exon 45 drug, and then Wave, as I mentioned, has this Steropure antisense, which again targets exon 51. So we've seen a lot of really exciting activity from a number of companies on this front. Here's just an example of a stop codon mutation. So the ribosome actually assembles the amino acids into a protein here. And if it actually reaches this premature stop signal in the cell, it stops assembling the protein. The amino acid assembly sort of ceases, and then you end up with sort of a foreshortened protein, which is actually too short and incomplete protein, which is non-functional and just disintegrates. So atalurin actually targets this stop codon mutation and actually allows for read-through of the stop signal, and the ribosome goes on to continue. Atalurin will actually allow the ribosome to continue assembling the full-length protein, and you go on to actually get a full-length dystrophin protein. The data looks pretty promising. It's actually approved in Europe. And trials are underway in the United States, hopefully to eventually get an FDA approval. Exon skipping, again, we're looking here at a situation where you have a particular gene deletion, which causes the gene to be actually out of sequence or out of frame. And so you get this foreshortened or truncated protein, which doesn't have a normal end to the protein. And with exon skipping drugs, here you have an out-of-frame mutation, but with the exon skipping drug, you can sort of cover up exon 20 it's like a genetic Band-Aid, which then allows exon 18 to be sort of read correctly with exon 21. And you just have essentially an internally shortened protein, but the two ends of the protein are normal and functional. So this is really how exon skipping works. So in this example, here's the normal dystrophin messenger RNA. So in this situation, the ribosome comes along, assembles a normal protein, a full-length normal dystrophin protein, in the setting of a exon 53 to 55 deletion, for example. It causes the reading frame to be disrupted, so 52 doesn't read normally with 56, and so you end up, the protein comes along, is assembled until you get to that area of the messenger RNA, and you end up getting this shortened protein and a non-functional protein, which essentially gets degraded, so that the protein is destructed, and you end up with complete absence of the dystrophin protein. In the setting of exon skipping of exon 52, if the medication can sort of cover up exon 52, so here the medication comes in, covers up exon 52, now you have actually an in-frame reading situation where 51 actually reads correctly with 56. The ribosome comes down, assembles the protein, and you end up with a functional protein, a little bit shortened protein, but a functional protein, because both the ends of the protein are normal. Here's just an example of sort of a typical Duchenne gait pattern in this patient. We could just start that video perhaps click it on at the back.
Fast as you can. Go, 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 go. Go, go,
Here you
go,
can
go.
see
Good
a
job, all the way
typical
down.
gait pattern.
Go, 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 go.
10-meter walk run. You can just see how tired he is at the end of that test. These are actually the youngest three patients that actually treated with an exon 50, exon 51 skipping drug, and they've actually been on this drug now. For each of them have been on this drug for over 3 years. And this is just recent studies. The young man on the right is 10 years of age, 8.5 years of age, and 7.5 years of age. These aren't just cherry-picked patients. They just happen to be the youngest three patients that I treated. So you can see these patients just don't look like Duchenne patients, even though the drug itself is producing relatively modest and low amounts of dystrophin. It doesn't take much dystrophin to actually have an effect on the disease. And just to finish with, in terms of the promise of gene therapy, here's a dog that actually has the Duchenne gene abnormality. You can see this dog is actually fairly weak, can't really jump over the pole here. And here's a dog actually treated with the AAV gene therapy, same genetic mutation. And this dog actually you can see, actually functioning in a pretty impressive fashion. And the preservation of function has lasted for up to 2 to 3 years in some of these dogs, again, treated with this AAV gene therapy. Here again, you can see the treated dog who's had the gene therapy treatment. So essential components of gene therapy: you have to have a vector to actually deliver the gene, a promoter which drives the expression of the gene into the intended tissues, in this case the muscle tissues, and then a transgene which produces a functional version of the protein of interest. So you really need all three of these components. The issue with the dystrophin protein itself, the gene is a huge gene, and the dystrophin protein, a large protein. But this gene is actually too large. The gene itself is too large to actually package into an AAV bus or a transmission vehicle. This carrying capacity of this is about 5 times 10 to the 3 kilobases. But the whole full-length copy is about 14. So it's kind of this situation here. You can see in the cartoon. You're going on a trip and you're trying to take a lot and pack it into a small suitcase. You just can't fit everything. So now you've got to sort of make decisions about what are sort of the essential components that are actually going to fit into the suitcase. And that's essentially what we've done with this. The companies, Sarepta, Pfizer, and Solid Biosciences are focusing on this now. This is the normal dystrophin protein. This was actually a dystrophin protein which was in a Becker muscular dystrophy patient who's still ambulatory at 61 years of age. But his dystrophin protein, which was internally deleted, was lacking 46% of the gene and the dystrophin protein. And yet this patient was still very functional at 61 years of age. So that gave us some clues as to what the essential components of the dystrophin gene were. And so companies like Sarepta, Pfizer, and Solid Biosciences are constructing these so-called microdystrophins, which are patterned after this patient who had Becker muscular dystrophy in the early 90s, was published to remain ambulatory into their 60s. So these microdystrophins have been sort of patterned after this patient's microdystrophin. So the microdystrophin actually can fit into the bus, into the vehicle. You just take these critical components of the dystrophin gene here and here, and actually allows you to actually fit it inside this AAV vector. You then put it with a muscle-specific promoter, in this case the MHCK promoter. The AAV in the Sarepta case actually is an AAV that's found in rhesus monkeys. The AAV that Solid and Pfizer are using is called an AAV9. And in this case, here's an example of one of these microdystrophins, which has just these critical essential components for the protein to actually be functional in patients. The initial publicly available data from Jerry Mendell from Nationwide with their microdystrophin AAV approach actually showed 81% dystrophin-positive fibers. So it looks very encouraging as far as this getting into getting dystrophin or the microdystrophin into the muscle fibers. And in fact, if you look at the CK values, these CK values in these patients just plummeted from 27,000 down to a low amount of 2,700, and then have stabilized over time. They're still not normal values, but this looks very encouraging. There's a number of unknowns in gene therapy: safety. What about what's called complement activation? Does the gene therapy get into the satellite cells? Remember, we talked about how important the satellite cells are to muscle regeneration. How durable is the effect going to be? Is this going to last for 5 or 6 years or longer? How functional would this tiny dystrophin substitute, the microdystrophin, be? Can patients be redosed years later when they've developed antibodies to the AAV? And then what about patients who have pre-existing antibodies to the AAV serotypes? What's the approach with those patients? So with that, I'll end. I don't know if we have any time for questions, but I think you can see the excitement really with the therapeutics in this disease. So thank you very much.
And we would just ask if you have questions, just maybe stand up or raise your hand and wait to ask your questions till we come with the microphone.
Great.
Hi. I don't know if I missed this, but are there any current therapies either that are available now or being developed that actually target satellite cells?
Well, I think some of these medications probably indirectly enhance the preservation of satellite cells, but there aren't any therapies that specifically target just the satellite cells. But I think a lot of the anti-inflammatories and these new medications that really enhance the pathogenesis of the system probably promote the survival of the satellite cells. That's a great question. Yeah.
I understood about 10% of what you said, maybe, but if the exon skipping is before like 41, then Adalurin is really the only therapy at this point that.
Well, there's theoretically exon skipping drugs that could target even some of the earlier mutations potentially. Right now, the ones I listed were the ones that are predominantly under drug development right now. But I think potentially, if you look at all the different exon skipping drugs together, could potentially target upwards of about 2/3 of all Duchenne patients. But unfortunately, for those who have mutations in the earlier exons of the gene, those aren't ones that are currently under active drug development by the companies. But I think down the road potentially could be targeted.
And would you put a number on what earlier is? Like, is it exon 25?
Well, I think right now if you sort of look at the hot spots of the gene being sort of exon 44 to 55, or those are predominantly where most of the exon skipping is sort of targeting that hot spot of the gene, which has a lot of the gene mutations. There's not a lot of exon skipping therapies that are sort of targeting below, say, exon 40 right now.
Okay. And then it seemed to me that being on steroids longer is better from what I saw and what you said.
Yeah, I think to the extent that you can tolerate the steroids, being on longer is better. I think there's still lots of patients who just can't tolerate being on the steroids into the older ages in particular. I think that's the exciting aspect of these new designer-type steroids that have much better side effect profiles, and I think will be much better tolerated for into the teenage years and beyond.
And are those available yet? Or?
They're currently under clinical trial, but the trials right now are focusing on steroid-naive patients who are 4 to 7 years of age.
Right.
But I think if the FDA approves these drugs, they're gonna give a blanket approval to probably a broad population of Duchenne patients, including teenagers, non-ambulant patients, and young adults.
And is there any kind of guesstimate of when those might be approved?
I think we're probably about 2 years away, would be my guess.
Okay. And would there be value in going back on steroids if they've gotten off of them?
Well, I think that's something you just have to probably take up with the treating physicians, and there's always risks and benefits to reintroducing steroids in teenage and adult years if the patient's been off steroids for a period of time. Some of the clinical trials actually require patients to be on steroids, so in some cases we will go ahead and treat with a fairly low dose, a more tolerable dose, just to allow access to a clinical trial and to a therapeutic.
Yeah, I'd say most of them require active steroid use,
Yeah.
from what I've been seeing.
Yeah, you're right. Absolutely. Yeah, there's a couple questions in the back.
Good morning. CRISPR research is a hot topic. Where do we stand with this is looking into a cure for DMD?
That's a great question. I think things are really actively moving forward with this gene editing or CRISPR-Cas9 approach. I think that right now one of the concerns is that if you deliver CRISPR with an AAV and the CRISPR just sort of gets integrated and hangs around for a long period of time, it's what's called a nuclease, which actually snips DNA. And so that CRISPR-Cas9 could actually just be sort of sitting around clipping DNA, and you could have some unintended sort of off-target effects, which might, produce things like cancer and so forth. So the idea would be a delivery mechanism where you could just sort of, for 2 weeks perhaps, the CRISPR could be delivered, and then the delivery vehicle would sort of go away, and the CRISPR would sort of do its job during that period of time. So I think that's what people are sort of focusing on, but we're probably, my guess is we're probably, for most of the CRISPR type approaches, probably at least 3 to 5 years away from clinical trials that are going to be taking that gene editing approach. There was another question in the back.
Oh, I guess I had a question about the Ultralurin, about as far as like having approval for that. Is there like a timeline for that? I know that's been.
It's a great question.
It's been a long time in the process, I know.
It's been since, I think, 2007. But it's approved in Europe. The FDA wanted to really see dystrophin levels, and so PTC actually is conducting a muscle biopsy study. That study's actually been completed. The patients still have to be on the Adalurin for about a year, and then they're going to do follow-up biopsies. And a lot of those biopsies were actually obtained down at UCLA. You'll hear from Stan Nelson later today. But the FDA has said if they're producing even small amounts of dystrophin on a consistent basis, that would be enough to provide a drug approval. The drug has now been used commercially in Europe for periods of about 6 to 8 years. And those patients that are on the Adalurin drug are actually doing extremely well in terms of their pulmonary function, their ambulatory function, upper limb function, and so forth.
I got a question. My son have a gene duplication. So I haven't heard much about the duplication. Is there any study about
There are some trials that are under development that are targeting some of these duplications early in the disease, like within the first 10 exons. There's some trials that are targeting duplications. I think the exciting thing is that the AAV gene therapy actually can include duplication patients, so that isn't an exclusion for being in a gene therapy trial. So I think gene therapy is probably the most promising approach to somebody with a duplication, in addition to some of the other therapeutics that are sort of mutation agnostic, that just target the underlying pathomechanism of the disease.
Hi, I'm glad you brought that up about duplication, because I know that early, the exons, like you said, 1 through 10, I'm not too sure what the exon range is, but Kevin Flanagan has research in that area for duplication, right?
Yes, absolutely. Kevin Flanagan from Nationwide Children's has an active therapeutic he's developing for duplications. I think it's within the first 7 or 8 exons. I forget the duplication he's actually targeting, but he does that. That's an active area of investigation. And the duplication patients with these therapeutic approaches, actually, it's not a shortened protein that's actually ultimately produced. It's a full-length dystrophin protein, which is pretty exciting.
And I also wanted to bring up, like you mentioned about idabidone, there's other drugs out there that are not exon specific. And,
Right. Yeah,
idabidone's
absolutely.
one.
So idabidone, some of these designer steroids, the Javinostat, HDAC inhibitor. There's a number of drugs now that and several that are going to come into trial this next year, such as the Astellas has this PPAR delta agonist, which targets mitochondria. There's quite a few drugs that'll be coming into clinical trials this next year that don't require specific mutations.
And Fibrogen is one of those as well.
Yeah, absolutely. So Fibrogen, that antifibrotic medication, that's going to target non-ambulatory populations trying to enhance arm function as well as pulmonary function. But patients with just a slight degree of upper limb impairment down to just having ability to, say, get the hand still to the mouth. But that'll be the target population for the Fibrogen trial this next year. I believe they are requiring steroids in that trial, or at least I think 6 months of lead-in steroids, I believe is the requirement. They also have some encouraging cardiac data with that Fibrogen compound as well. That's where, rather than a deletion where you're actually missing a portion of the gene, you actually have sort of an added exon that's sort of stuck in there that disrupts the reading frame of the gene. Yes.
All this medication sounds great, but what are the side effects for patients with Duchenne?
That's a great question. I think the side effects are really quite varied depending on which drug you're talking about. So if you really need to talk to your physicians when contemplating a clinical trial and find out what some of the potential side effects are. Some of them can be quite different from one another. The Javinostat drug, which is the one that the Italian company actually, Italfarmaco, is looking at, that actually can drop your platelet count down, which could put you at risk for bleeding problems. Usually, if the platelet count drops, then the dose can be modified. Other drugs all have their own very specific potential side effects, but most of the drugs here that we've looked at, the side effect profiles are pretty reasonable. But you just have to talk to your physician about what those side effects are. And even with the gene therapy, we still just don't know the safety profile, really. We haven't used it in enough patients to know what type of unintended consequences there could be in terms of complement activation, inflammation, and other sorts of side effects. But that's a great question.
Thank you very much, Dr. McDonald. Oh,
Okay.
we've got one more.
Yeah, the steroids itself will sort of knock down those microRNA levels just with the steroid production. And as well as targeting these other pathways such as NF-kappa B, which enhance the survival of the muscle fibers. Okay, great.
That's Dr.
Okay.
McDonald.
Great, thank you.